chosen emphysema as our topic. I'm Radhika, this is Swetal, that's Randima and Jasmine. Okay,
and now for our case study. So we have Mrs. Katherine Wilson, born on the 5th of October 1958. She's a 58-year-old widow who was presented to the emergency department a day ago with a severe case of dysapnea and smoker's cough. She's an English native living in the suburb of Pascoe Vale. Mrs. Wilson was previously a full-time high school English teacher. However, due to her ill health, she has retired and is providing private tutoring. She has a daughter, Susan, and a son, Robbie. Both her children have moved out, but Mrs. Wilson only keeps contact with Susan, who lives 2 suburbs away and comes to visit once a week. Mrs. Wilson has a past medical history of asthma and dysthymia. For 7 years, the regular use of Ventolin has helped her to control her asthma. The death of her husband in 2012 led to mild depression. However, she is currently in a much healthier mental state due to past cognitive behavioral therapy sessions. She has been a heavy smoker, 2 packets a day for the past 30 years and continues to follow this pattern. Mrs. Wilson has sought medical attention due to shortness of breath when doing brisk activities, worsening airflow limitations, and an uncontrollable cough, expectorating tenacious yellow mucus. Her admitting diagnosis is stage 3 chronic pulmonary emphysema with acute exacerbation. Her vital signs are as follows: respiratory rate 32 and laboured pulse 114 beats per minute, and the oxygen saturation is 67%. Physical examination revealed decreased breathing sounds, wheezing, and cyanotic skin.
Pathophysiology of emphysema. Emphysema is a pathological diagnosis used to describe a chronic disease of the lungs in which there is enlargement and deterioration of air spaces distal to the terminal bronchioles. It is a progressive condition and the most common type of chronic obstructive pulmonary disease. It is non-curable and irreversible. However, the severity of the disease can be slowed down through behavioral changes, careful care and management of infections, and appropriate rehabilitation actions. Emphysema causes permanent parenchymal destruction, which is the portion of the lung involved in gas transfer, namely the alveoli, alveolar ducts, and respiratory bronchioles. It also leads to airway dysfunction. Put together, this damage causes expiratory airflow limitation and decreased gas transfer. The condition causes damage to the alveolar walls, alveoli, and lung tissue. This in turn results in alveoli no longer being able to support the bronchial tubes, which collapse, and thus the obstruction in the airway is caused, leaving air within the lungs. Alveoli are key to pulmonary gas exchange. Tobacco smoke, pollution, and other irritants damage alveoli, causing them to become swollen and thickened, resulting in narrowing of the lumen. The irritants also cause them to lose their elasticity, and as a result air gets trapped within the alveoli, stretching the walls, and eventually causing them to burst or break down. Once broken down, they join to other alveoli and create larger air pockets, known as bullae. If the bullae enlarge and burst, they can cause pneumothorax or collapsed lung. As air is already trapped within the alveoli or bullae, inhalation causes the walls of the lungs to stretch even further out. The lack of air transfer occurring expands the lungs and causes them to lose their elasticity and destroys the tissue. As a result, even more carbon dioxide remains within the lungs, leaving less space for fresh air, thus causing shortness of breath and dyspnea. The continuous stretching and expansion of the lungs, chest wall, and ribs leads to hyperinflation. Ultimately, the loss of elasticity makes it more difficult for the lungs to ventilate. Due to the loss of alveoli and increased inflation of the lungs, only a small amount of pressure difference is needed for them to inflate, and so lung compliance is also increased. A patient suffering from emphysema would require to use their accessory muscles. This is due to the fact that hyperinflation causes pulmonary organs to encroach the diaphragm, flattening it. Normally the diaphragm moves downwards, pulling air into the lungs during inhalation. However, the lack of room caused by hyperinflation does not allow for complete movement, and so patients are forced to use the accessory muscles, the chest and neck muscles. The patient, Mrs. Katherine Wilson, is a heavy smoker, which is known to be the leading cause of chronic obstructive pulmonary disease. The patient has a severe case of dyspnea, smoker's cough, shortness of breath whilst performing physical activities. All signs and symptoms of emphysema. The patient also suffers from acute exacerbation, which is commonly associated with inflammation of the airways. Inflammation of the airways is generally triggered by infection. The tenacious yellow mucus expelled by the patient is suggestive of either infection or mucus buildup within the airways, another symptom of emphysema. Differences between normal and dysfunctional states. A person suffering from emphysema would show ventilation perfusion defect, leading to hypoxemia or hypercapnia. Ventilation perfusion ratio is the balance between ventilation, the bringing in of oxygen and removing of carbon dioxide from the alveoli, and perfusion, the removing of oxygen and the addition of carbon dioxide to the alveoli. Dyspnea, due to the obstruction in the airways. Increased working of breath. Weight loss. This is due to muscular deterioration and increased working of breath, which leads to decreased ability to perform exercise and physical activity. The body is unable to supply an adequate amount of oxygen to muscles and tissues for the person to maintain a healthy level of fitness and energy. Increased dead space in lungs. Dead space is the volume of air that is inhaled that does not take part in gas exchange. This is due to the fact that it reaches alveoli that are poorly or not at all perfused. Destruction of the tissue, reduced surface area, leaves few capillaries for gas exchange. This picture depicts an emphysemic lung and a normal healthy lung. The normal healthy lungs are rich in functioning alveoli and capillary beds for sufficient and quality gas exchange, as compared to the emphysemic lung, which shows large air spaces. Potential complications. Potential complications of emphysema include right-sided heart failure or cor pulmonale. As the alveolar walls break down, the pulmonary bed is reduced. Pulmonary blood flow is increased, causing the right ventricle to maintain a higher pressure in the pulmonary artery. This, along with hypoxemia, can lead to cor pulmonale. Pulmonary hypertension, which can eventually lead to right-sided heart failure. Respiratory failure. This is due to the airflow obstruction, a result of the airway being narrowed, thus an increase in airway resistance. Cachexia and muscle dysfunction or deterioration. This disease does not allow for sufficient exercise in order for muscles to be retained or maintained. This can lead to severe weight loss, nutritional defects, and, as a result, an impaired recovery. The degeneration of ventilatory muscles and dysfunction of it through a sustained inflammatory response caused by emphysema can cause muscle wasting a lot faster than the gradual process it usually takes. Pneumonia. A person with emphysema is more prone to pneumonia, a bacterial infection of the alveoli and bronchioles. If combined with chronic obstructive pulmonary disorder, pneumonia can cause the severity of exacerbations to increase. Pneumothorax. Some lungs develop large air pockets called bullae, which may burst, resulting in lung deflation.
Pharmacological interventions for the treatment of emphysema. The treatment of emphysema involves the use of drug therapy to reduce and manage common symptoms such as breathlessness, coughing, and chest pain, and to combat exacerbations or infections that may occur. Drug therapy cannot reverse the damage already done by COPD, and the main purpose is to maintain the patient's current state and relieve any symptoms the patient may be experiencing. There are two main groups of drugs that are used for the treatment of emphysema. The first are bronchodilators that help facilitate breathing by dilating the bronchi, and inflammatory agents that combat inflammation during acute exacerbations and infection. Bronchodilators are the first choice medications and act by relaxing the smooth muscle of the bronchi, which opens the airway and relieves respiratory symptoms and prevents bronchospasms associated with COPD. Xanthines are a subgroup of bronchodilators used for the relief of symptoms, prevention of bronchial asthma, and reversal of bronchospasms associated with COPD. However, due to a relatively narrow margin of safety and adverse reactions with other drugs, they are no longer a common choice. Adverse effects occur due to the buildup of theophylline levels in the blood, which can cause problems from nausea, hypoglycemia, tachycardia, and in some cases death. Xanthines used to treat respiratory disease include aminophylline and theophylline. These drugs act by stimulating two prostaglandins, which relax smooth muscle within the bronchi, and thus increases vital capacity to facilitate respiration. They are also useful in reducing swelling and narrowing of the airways by inhibiting the release of inflammatory mediators and histamines. Due to the metabolism of xanthines in the liver, there are many adverse drug reactions that may occur. Nicotine, for example, increases the metabolism of xanthines, and the dose should be adjusted accordingly for people who continue to smoke. Extreme caution should also be taken for people who decide to decrease or stop their smoking habit while on these drugs, as xanthine toxicity can occur. Sympathomimetics, another bronchodilator, are used to treat respiratory distress associated with emphysema and include ephedrine, salbutamol, salmeterol, and tubutaline. These drugs are beta-2 agonists which stimulate the beta-2 receptors within the bronchi. They mimic the effects of the sympathetic nervous system and relieve symptoms by increasing the rate and depth of respiration, resulting in bronchial dilation. Much like xanthines, these drugs should be used with caution in patients suffering from conditions that would be aggravated by sympathetic stimulation. Other than respiratory stimulus, these drugs also increase blood pressure and heart rate, enable vasoconstriction, and decrease renal and gastrointestinal blood flow. The final bronchodilators are anticholinergics. They are not as effective as sympathomimetics, but are used in patients that cannot stand the systemic effects of other drugs. Anticholinergics block the action of the neurotransmitter acetylcholine at vagal-mediated receptor sites, which in turn relaxes smooth muscle in the bronchi. There are two drugs commonly used, ipratropium and tiotropium, both of which are available for inhalation through an inhaler. Caution should be used in patients suffering from glaucoma, prostatic hypertrophy, and bladder neck obstruction, as these conditions may be aggravated by the anticholinergic effects of the drug. There is an increased risk of adverse reactions if these drugs are mixed with other anticholinergics, and this combination should be avoided. Anti-inflammatory agents. These are secondary medications used for the treatment of emphysema and include inhaled steroids. They have been shown to improve lung function in people with COPD when added to a medication regime that includes a beta-2 agonist. This combination shows improvement in ease of breathing, reduction of inflammation, and a decrease in exacerbations. Inhaled steroids, known as corticosteroids, are used for the treatment of bronchospasms and inflammation. They decrease the inflammatory response in the airway by reducing the effectiveness of the inflammatory cells in the lungs. This has a systemic effect on the respiratory system and decreases inflammation while also promoting smooth muscle relaxation and bronchodilation. Inhaled steroids should be used with caution for any person with an active respiratory infection, as these drugs suppress the inflammatory response and this could lead to serious illness. Due to the route of administration, adverse effects are limited, but may include dry mouth, headache, sore throat, coughing, and potentially a sinus infection. So, which drugs do we use? For our patient, Miss Wilson, there are some common contraindications that will impact on the use of certain medications. As she is an avid smoker, xanthines should be avoided because these have a narrow margin for safety and are metabolized faster with the help of nicotine. If she were to quit or reduce smoking, xanthine toxicity may occur. They also have adverse interactions with many other drugs, including Ventolin, and would not be the best choice for our patient. For the quick relief of exacerbations, it is recommended that a short-acting bronchodilator is administered. Ipratropium is a good choice for quick relief of symptoms, as it has an onset of about 15 minutes and a peak effect within 2 to 4 hours. It also comes in the form of an inhaler for quick administration. For the management of COPD symptoms over a long time, long-lasting bronchodilators are used. They are taken daily over an extended period of time to gradually help with breathing. Ms. Wilson is already taking Ventolin for the treatment and prophylaxis of bronchospasm and acute asthma attacks, and this medication should be continued. The best medication to administer would be salmeterol, as this does not have adverse interactions with Ventolin and provides therapeutic relief. Steroids can also be used for the relief of symptoms of emphysema, but should only be added to a regime that includes a long-lasting bronchodilator. Combined with the long-acting beta-2 agonist, such as salmeterol, inhaled steroids increase lung function and decrease breathlessness and exacerbations.
Nursing management of emphysema. Emphysema treatment goals have three domains. 1. Relieving patient symptoms. 2. Slowing progression of disease. 3. Mitigating the risk for cardiovascular disease and lung cancer. Patient symptoms. Nursing diagnosis 1. Ineffective airway clearance due to expectorating tenacious yellow mucus and expiratory airflow obstruction. Nursing and patient goal. Patient is able to maintain a patent airway as supported by reduced or no wheezing and short-term relief for Mrs. Wilson of emphysema symptoms such as airway clearance and ability to breathe easily. Nursing interventions. Control airway inflammation through prescribed anti-inflammatory medication, making sure Mrs. Wilson continues taking her Ventolin 2 inhalations every 2 hours. Assessing lung sounds every 2 to 4 hours, along with obtaining a set of vital signs every hour. Mrs. Wilson is to sit in a tripod position when experiencing difficulty breathing. Monitoring relief of symptoms every hour, ensuring hydration through the use of fluid balance chart 2 to 3 liters per day. Encouraging coughing, deep breathing, and turning every 2 to 4 hours. Perform a sputum assessment. Evaluation. On admission, Mrs. Wilson had decreased vascular breathing sounds, prolonged expiration, and due to over-distension of lungs, muffled heart sounds, and occasional wheezing. Assessing lung sounds every 2 to 4 hours will notify nurses of whether Mrs. Wilson's health is improving. Anti-inflammatory medication should reduce the swelling of the airways and prevent shortness of breath and wheezing by decreasing the sensitivity of the airways to irritants and allergens. Regular fluid intake will aid to liquefy secretions for easier expectorations. Yellow, orange, or green sputum is commonly associated with bacterial infection, and by performing a sputum assessment can provide clues about Mrs. Wilson's health, whether Mrs. Wilson requires antibiotics. Nursing diagnosis 2. Low oxygen level in blood causing shortness of breath. Nursing and patient goals. Reduce the respiratory rate, increase oxygen level in the blood. There is no evidence of cyanotic skin. Begin discharge planning. Nursing interventions. Assisting Mrs. Wilson to increase her blood oxygen by providing oxygen at no more than 28% via venturi mask, 4 liters per minute or no more than 2 liters per minute via nasal prongs, and aiming for oxygen saturation between 88 to 92%. Monitor the oxygen level every hour. Taking a sample of blood to make sure the arterial blood gaps 20 minutes prior to beginning oxygen therapy. Keeping Mrs. Wilson warm by increasing the heating and providing her with extra blankets, as well as the oxygen therapy, will treat cyanotic skin. Susan is to be contacted and informed of her mother's condition. Evaluation. Along with other treatments, anti-inflammatory medication, tripod positioning, hydration, oxygen therapy will help to increase her blood oxygen level as it is dangerously low, 67%, and manage to decrease her respiratory rate to safe levels. Abnormal blood gas results indicate Mrs. Wilson is not getting enough oxygen or not getting rid of enough carbon dioxide, or there is a problem with kidney function. By contacting the closest family member, nurses can plan on Mrs. Wilson's discharge. Nursing diagnosis 3, heavy smoking pattern worsening Mrs. Wilson's health. Nursing and patient goal, begin process of smoking cessation with the consent and support of Mrs. Wilson herself. Stage 1 smoking cessation is pre-contemplation. Nursing intervention. Holding an informative discussion on smoking cessation and outlining the benefits of it with the support of Susan. Evaluation. Stage 1 pre-contemplation. Consists of not thinking about quitting, and if challenged will most likely defend their smoking behavior. However, at some point when provided with enough information, facts and motivation from healthcare practitioners as well as family, the great majority of pre-contemplators will start thinking about quitting. 2. Slowing progression of disease. Nursing diagnosis 1, smoking tobacco subjects the lungs to irritants which have a long-term detrimental effect on the lungs. Nursing and patient goal. There is no or very little exposure to irritants. Achieve stage 2 of smoking cessation, which is contemplation. Achieve stage 3 of smoking cessation, which is preparation. Nursing interventions. Encourage Mrs. Wilson to quit smoking by getting the support of healthcare practitioners and her immediate family. outline the consequences of smoking and the negative effect it will have on her emphysema, set small goals such as reducing the amount of cigarettes she smokes, 1 per day. Evaluation. During contemplation stage, Mrs. Wilson will consider quitting. She will be more aware of the personal consequences and consider smoking a problem that needs resolution. She will be open to receiving more information about smoking and identifying the barriers that prevent her from quitting. During preparation, Mrs. Wilson will be getting herself ready to quit smoking. It is important as a nurse to make sure she takes small steps towards quitting. This will help with relapse prevention. Nursing diagnosis 2. Shortness of breath when doing brisk activities and heart rate higher than normal. Nursing and patient goals. To increase lung capacity gradually with the support of physiotherapist, and Mrs. Wilson encouraged her to attend physiotherapy sessions. Achieve stage 4 of smoking cessation, action. Heart rate within normal ranges. Nursing interventions are encourage regular exercise beginning with very simple cardio routines such as walking and then eventually increasing the intensity of the exercise. It is important to not push Mrs. Wilson too much at first, especially before beginning to increase her lung capacity. Set a schedule for Mrs. Wilson to attend physiotherapy. Mrs. Wilson should have a firm action plan on quitting smoking by this stage. Evaluation. Exercise can slow the deterioration of Mrs. Wilson's lungs and increase her lung capacity if it is done regularly. Stage 4 of quitting smoking requires the presence of supportive family, friends, and healthcare workers. Thus, the presence of Susan would be crucial. Mrs. Wilson will be actively trying to stop at this stage, and providing short-term rewards will help keep her motivated. Within 20 minutes of quitting, Mrs. Wilson's heart rate will start to drop back to normal. Mitigating the risk of cardiovascular disease and lung cancer. Nursing diagnosis 1. Mrs. Wilson's ability to maintain healthy lifestyle. Nursing and patient goals. Achieve stage 5 of smoking cessation, which is maintenance. Mrs. Wilson continues to exercise regularly and her diet consists of nutritious food. Nursing interventions. Prior to Mrs. Wilson's discharge, she is well educated on the ways that can help her quit smoking. She is given contact details of organizations which can help her to quit and continue to be a non-smoker. Suggesting and helping to set up daily exercise routine, which may include her daughter Susan as well. Slow-paced walking every morning for 30 minutes and increasing the intensity over a set period of time will aid Mrs. Wilson to expand her lung capacity. Evaluation. Former smokers in the maintenance stage have learned to anticipate and handle temptation to smoke and are able to use new ways of coping with stress, boredom, and social pressures that have been part of their smoker's identity. Although Mrs. Wilson may slip and have a cigarette, she will try to learn from the slip so it doesn't happen again. This helps to give her a strong sense of control and the ability to stay smoke-free. When Mrs. Wilson's family and friends are participating in activities such as walking or even eating together, as a family, she will feel more supported.
The 10 NSQHS standards were developed by the Australian Commission on Safety and Quality in Healthcare to protect patients from harm and improve the quality of healthcare services. In the case of Mrs. Wilson, Standards 2, 3 and 3 are applicable. Standard 2. Partnering with consumers. This standard aims at creating a health service responsive to patient input and needs. Patients are supported by health service organizations to actively participate in their own care management, thus improving patient experience and health outcomes. Standard 3. Preventing and controlling healthcare-associated infections. This standard looks at preventing patients from acquiring preventable healthcare-associated infections when they occur by using evidence-based strategies. Proper management and treatment of infected patients, safe antimicrobial prescription, proper hygiene of the healthcare workers, cleaning of equipment and environment can help reduce infections.
Standard 4. Medication Safety. This standard requires that health service organizations implement systems to reduce medication errors and encourage safe and quality medication use. A good system will involve provision of patient-specific medications and proper medication education which the patient understands and includes things like side effects, dosage, and treatment options.